your body is meant to serve you. So you should not have pain. You should have dry pants. You should have enjoyable sex.
I remember the first time I heard physical therapy can help you stop leakage. I'm like, bullshit. Is it safe for women to have sex if they have that leakage problem? Should they stop?
So if you are a woman who is thinking about getting pregnant, if you're currently pregnant, or if you've had any amount of babies in your uterus, you're going to want to tune in. I am chatting with Diana, a mother of 3, about all things postpartum incontinence, what really happens when we leak, and is there anything we can do to truly take care of the problem, or is surgery in my future? Thanks for joining us.
Beautiful. Doc, before we continue, can you tell us a little bit about you and what you do so that, you mentioned I'm a mom of 3, but give us your credentials.
Yeah, thank you. So I am a doctor of physical therapy, and I specialize in the pregnant and postpartum woman. 8 years ago, I started a phenomenal company called Painless Pregnancy, and we are a big team, all doctors of physical therapy who specialize in this population, and we serve them in the comfort of their own homes to help them have the most successful pregnancy, delivery, and postpartum recovery possible.
Whoa, that is beautiful.
Yeah.
What I love about this conversation is that nobody talks about, or it's not common to
Right.
talk about leaking and peeing and all that not so fun conversations. There's a lot of reels making fun of it, like, like moms walking and before they sneeze, they cross their legs and they sneeze and they're like, thank you, baby. But that's the most of it.
Yep, so true.
But what do we do once we're in that? Because that can feel fun in a reel,
Right,
but
right.
In an everyday life, not so much.
Not so much. Yeah, it is not fun. And you're correct. It is becoming more popular to speak about it. And we are starting to recognize that peeing your pants during pregnancy or after is super common. We say it's not normal because your body is meant to serve you. So you should not have pain. You should have dry pants. You should have enjoyable sex. And anything that stands in your way of those things should be corrected. And now what I love about what we do is it is conservative treatment. So we are not medication, injections, or surgery. We are strengthening and stretching, and we are intelligent bone mobilization and alignment and posture and all things that not only can correct your problem, but restore your body to its maximum state.
And I don't know about any of the listeners, but I remember the first time I heard physical therapy can help you stop leakage. I'm like, bullshit.
Did you really?
Yeah, I was like,
Oh, that's
how
funny.
can that help? Like,
Yeah.
what the hell?
Yeah.
So, Doc, enlighten us, because I could see
Right.
people going like, I don't know about that. So
Yeah.
how can physical therapy help women who are suffering from that discomfort?
Yeah, absolutely. And I'll even clarify too, we have helped women who tinkle a little bit when they sneeze, and we've helped women who lose their entire bladder just from standing up.
Wow.
And so the reason that we can help is because the cause of the incontinence, which means leaking, right? And that can be gas, bowel, or urine beyond your control. For this conversation, we can stick to the conversation about urine leaking. The cause of it is physical. So if there is any change to the pelvic floor muscles, now remember, muscles have characteristics like strength, length, position, that can all affect how well they work. So if it has anything to do with the pelvic floor muscles, we can help. If it has to do with the pressure inside the abdomen being greater than what's happening in the pelvic floor, we can help. If it has to do with how your rib cage is lined over your pelvis, or how strong or tight your abdominal wall is, or even if your throat, the way you manage to hold your breath, whether you're exercising, having a bowel movement, singing, anything like that, your throat and your pelvic floor are intimately connected.
What?
Again, muscle groups, pressure management, that's our jam. We help with all of that.
Okay, say more. What? What do you mean they're connected?
Yes. Okay. So if we can bring it to the basics with the pelvic floor, you know, the first layer broke a couple years ago. This is the first layer. It pops on and off for demonstration. And I kept it because my first layer broke too. And I still stick with her. So this is your pelvic floor muscles if you take the skin off. Okay. And so they attach from our sit bones. So if you're sitting right now, you can put your hands under your bottom and move your feet in and out. You should feel your sit bones. Okay, they're at the base of your pelvis. So your pelvic floor muscles attach to your sit bones and to your tailbone. Okay, so this tendon should be connected to the tailbone here. So those muscles go through tremendous amounts of changes during a pregnancy and especially with a vaginal delivery. And I point out during a pregnancy because sometimes women will call us with pelvic floor issues, incontinence, pain with intercourse, and they'll say, but I had a C-section, so I don't know if you can help me because it has nothing to do with delivering. And we're like, wait, no, but you carried a baby for 9 months. Like your pelvic floor went through a lot of changes. Your pelvic bones went through a lot of changes, right? They got thicker, they got wider, they moved position. Like we can help with that. And so one of the things that I think is a great visual to understand, if you did have a vaginal delivery, this is something that one of my mentors, Lynn Schulte, taught us at the Institute of Birth Healing, that our pelvic bones move in a predictable pattern during a vaginal delivery. So we can use that pattern of bone movement to reverse engineer and correct what we see postpartum. Okay? Because our pelvic floor muscles attach to these 3 bones and they create like a hammock. So if this is upright, tailbone, pubic bone, sit bones, our pelvic floor is the hammock at the bottom, okay? The muscles are holding on to the bones. They're attached.
Okay.
For a baby to come out, first they have to come into our pelvis, this space here. So they have to come in here. The bones move like this. Can I show you with the baby? Are you okay?
Yeah, please. It's a little bit like, whoa.
I know vaginal deliveries was not your thing, so you let me know.
Yeah, you do it.
So
you do it. Show us.
Typically, the babies come into the pelvis looking to the side. So that's what the head shape is, to the side. So they come into the pelvis here. And it helps when the bones move. The iliums come out and the sacrum comes under. The tailbone tucks under, okay? See how that widens the space where the head can go in? Whereas if the sacrum is lined up and the pelvic bones are lined up, that's a tight space. You see that? Okay, so it's about the head position. So we work with our moms to allow this pelvic inlet to open up. Then when the baby comes out, the pelvic outlet has to open up. So the baby's already in. Typically, hopefully, they look face down because that's easier, the easiest position, though we can really birth babies in quite a number of positions. Then the pelvic floor muscles have to stretch maximally to open this space and let the baby come out.
Got it.
Okay, typically head first and then the shoulders. Whoop, then
and when their babies are standing up or bottom first.
Bottom first, feet first, yeah. That's a whole thing. A whole thing. Yes. The main message with that
sounds so painful.
I mean, it can be, but it's pretty phenomenal that these bones can move as much as they do. And truthfully, I mean, they don't need to move this much. It's millimeters what we're checking for. Typically, we get them either face up, the moms face up or face down, and we're able to mobilize through here and get this sacrum to be flexible in all planes during their pregnancy so that there should be no bony blockage to that baby coming into the pelvis and out. Does that make sense?
That makes total sense.
And not only do we mobilize the bones, but then we release the soft tissue, glutes, low back, inner thighs, outer thigh. Like we do really effective massage and myofascial techniques to make sure that the muscles don't just pull the bones right back to where they were, right? Because we know the body has habits, postures,
memory,
tendencies. Yeah, memory. So if we don't intervene after we mobilize the bones, we massage, we stretch, and we strengthen. So it's like all roads are leading to this pelvis being able to move. Okay? So, back to incontinence.
Yeah, I was like, what does this has to do with
Yeah.
with leaking?
Yeah.
I mean, it has everything to do,
has
but I'm like,
everything.
okay, the baby's out. Now I'm peeing
Right.
everywhere.
The
What
baby's
happens?
out, now I'm peeing everywhere. So it could be a consequence of having trauma, or even simply, like you could say, a tear to the pelvic floor muscles. So the most common place to tear, though we can tear anywhere, is the perineal body. That's the space between the vaginal opening and the rectum. Okay? I have a really great model. Okay, so these are vulvar models, which most people would want to say this is a vagina, but the face of the vagina is a vulva. And so typically we tear down here. And so that is the common tendon for many pelvic floor muscles. So you get a tear here, you have quite a few muscle groups that are now impaired. One of the functions of your first layer of pelvic floor is sphincteric. That's a circular muscle, and it closes from an open circle to a closed circle. That's like the, in a pipe, that's like the...
Opening valve and
A valve to a pipe, thank you. So you cinch that when you're trying to not urinate. So it's not like, that's an easy one to understand, right? If you have a tear in a sphincteric muscle, it can no longer close at the bottom of a tube and liquid flows out, right? The other common contributor to not being able to keep urine in is if you have too much pressure inside the abdominal cavity. It's again a factor of weakness, but if we have this distended abdomen that's kind of swollen, we're bleeding anywhere from a week to 4 or 5 weeks postpartum, the uterus is coming back to a smaller size, there's a lot going on intra-abdominally. So if we have pressure from that, if we have bloat from eating on the go, if we're full of fecal matter because we don't have time to sit and empty our bowels, or we're suffering from incontinence, inactivity, poor diet can contribute to constipation. So any of those factors that will make the inside of your belly feel heavy, swollen, or bloated. You're adding weight to what the pelvic floor muscles have to do to keep stuff inside.
And they're weak.
And you're weak. Yeah. I mean, you don't have to be, but typically we are.
I know, Mom, I'm sorry sharing this secret, but I know my mom teared while having me.
Yep.
So it went all the way down to her anus. So it's like, per thing.
Yeah.
That was one of the most terrifying things for me to think about pregnancy. So what happens in the healing process of that? Like, is that part of what you guys help?
Yes.
How soon can I see you if I'm like stitched up in there? Like,
Right. Yeah, absolutely. So yes, that's a common question too, even from physicians. It's funny, I have to tell you, one of the therapists that works with me, she called me and said, Kat, I have to tell you, I was with a patient. She called her OB while I was with her on speaker. The nurse answered. She said, listen, I know I'm not at 6 weeks yet, but my therapist is here. We want to know, if we can do such and such. And the nurse goes, oh, no, you can't do pelvic floor therapy until week 6. The physician was standing near the nurse and he heard her. And he goes, who is she with? And the nurse goes, Painless Pregnancy. And he goes, oh, yeah, they can work with her. Like, just like that. He was like, they know what they're doing.
Yeah.
And it was amazing. Because, we don't touch the pelvic floor space while it's healing. I mean, sometimes when we go see moms postpartum, they'll be like, can you look at my stitches because I felt this or I saw this? Absolutely. Gloved hands, part the tissues. Let me tell you about where you're at healing-wise. So we don't disrupt or touch the pelvic floor muscles or tissues during that 6 weeks. And we do totally respect, we don't do any intervention internally until an OB or a midwife has cleared that patient.
Perfect.
100%. What we can do is a lot of other stuff. So I'll share with you one thing that helps tremendously when we come and intervene before that 6 week is the common birthing pattern. So when these bones get stuck in this open position, because they have to do this for the baby to come out. So when they do that, the pelvic floor muscles stretch tremendously. I mean, I've seen numbers like 8 times their natural size or even more. When muscles are stretched that far, and typically for a good amount of time, right? Like some women push for 10 minutes, some women push for 2 hours.
Yeah.
And then, I don't know if you heard about this, the ring of fire that they feel. So when the baby's head actually stretches the vaginal opening, sometimes it can be a slow process, and that's actually okay because the head comes down and it stretches those tissues maximally, and then it kind of backs away. And then it stretches them and it
Is
backs
that the
away.
contraction that we're feeling?
The contractions will consistently push and relax and push and relax. What I was told is that the baby crowning can be a slow process because it is actually favorable to muscles to stretch slowly over time. If I were to take your hamstring and stretch you and just bring your leg wakata, like straight up to your head, you'd be like, oh, yeah, stop. That's tight. But if I were to hold it just at that threshold where you're like, yeah, I feel a little stretch, and then I would bring it down. And then another minute later, I'd push it a little further and just hold it for 30 seconds, a minute, and then bring it down. In 20 minutes, I could probably have your leg pretty far stretched, and you would never be like, oh, stop it.
My only thought when you're saying that is that safe for the baby? Isn't the baby gonna suffocate? Like, what happens with the baby? I'm like, what happens with the baby? Because that's like my instinct as a mom. Like, and also, can you get this baby out of me?
I know. Please? Yeah, it's true. Typically, when you're at that stage, you're like, I'm done. Grab them, suck them out, whatever you need to do. Yeah, it's hard. As a physical therapist, I understand that is super helpful. Like, it really is. So it can feel like the ring of fire. My theory is that if you are going to use the word fire, that's possibly a tight pelvic floor that's being stretched for the first time.
Wow.
Like, or maybe there's some mild tightness or tweaks in the bones, but when that baby's head comes down, it's stretching maximally and then coming back. And so ideally, you're going to do that for at least a few reps before they come all the way through.
The other question I have, as you're saying that, is it safe for women to do physical therapy? Because what you're saying feels as if, like, the way that I'm receiving it is like the woman is about to give birth and this particular woman has never had any support by someone like you, and she's in that stage. Mm-hmm. If me doing that before to prepare for that, wouldn't that induce labor? Like,
oh, that's a great question.
To me, that's like scary because I don't know, and I don't want to do I don't want to do something that is going to put me in that, like preparing myself to do that. And then it's like, oops, baby's coming, help.
Yeah, that's a great question. So I love this because if we could induce labor, our lines would be wrapped around this building. Inducing labor, helping a woman start the labor process, completely out of our realm.
Okay.
We can support her in being prepared for when that event does start. But touching the pelvic floor, massaging it, teaching her pushing strategies, none of that has been shown to start labor.
Okay, perfect.
Yeah.
Because that feels like...
Yeah. Oh, and you're not alone. Yeah. A lot of women will ask that. Like, oh, I'm only 36 weeks. Should I start birth prep because I don't want to go into labor? Absolutely.
Okay.
And, like, you'll be really asking us to help you start labor at 41 weeks, and we'll still say, you can go to acupuncture, you can have sex, you can do nipple stimulation with a pump. Like, there's things that you can do that have been shown to start labor. That's not us.
Okay, good.
Yeah.
But it does prepare women physiologically to get those muscles like activated, or I don't know if that's the right word.
Yeah. Yes. So we rehearse for the big event. We really do. So we set the bones up for proper movement capacities. We set the muscles up to be flexible and strong and to have the right coordination for bearing down, for pushing, for relaxing. Like, a lot of birth is a surrender process. So, like, they should be able to know how to connect to their bodies and release their pelvic floor. I mean, you talk to any birth worker and they will tell you it is a common thing for women to tighten their whole body with contractions, with position changes. So if you can even just rehearse that, and she can be in the moment and be like, oh, this sucks. Wait, I know. Let me breathe. I know it's going to suck, but I'm going to ride this wave instead of pushing against
Fighting
it.
it.
Yeah, it's training. It's training. I mean, we compare it to, like, we've worked with women who've run marathons, and we can prepare them for that. Not a single one of them has said, oh, but you've never been to the Disney Marathon, Kat, so you can't prepare me for that. Or like, you don't know what the weather's going to be like, so you can't prepare me for that. Or like, you know, I need to buy shoes. I don't have the right shoes yet. Maybe I shouldn't train. What? No, you're going to run a marathon. Like, start running today.
Yeah.
And granted, did you know, like, typically, if you're preparing for a marathon, you don't run 26 miles every week. There's a path to it. It's like a 5-mile day, and then a 10-mile day, and then a 13-mile weekend, but then a 2-mile day, right? Like, you pace yourself. So even though you're not truly going through every single motion that you would do in your delivery, and there's a lot of factors that you don't know about, you can still train, and you should.
That's such a powerful thought. I have never thought about that in that way. Like, I'm just having like an aha moment as you're saying that. Like, why didn't I train for this?
Yeah.
Why haven't, it's like, your body knows. Don't worry. I'm like, I don't know about that.
Right. Right. You're like, actually, I had a long conversation with my body, and it doesn't know. It doesn't like the idea.
I don't know about you, but yeah. And so then what I'm hearing you say is being able to do physical therapy can help your muscles create some awareness so that when the moment comes, even if you have a C-section or a vaginal delivery, you're less likely to leak after that. Is that a true statement?
Yeah, absolutely. Absolutely. Yes. Even just on muscle connection alone. So we do prehab for other surgeries fairly routinely. I mean, oftentimes patients will come to us if they know, not painless pregnancy, but back when I worked at the hospital, if they knew they were going to get a knee replacement, they would go in and get a little therapy. Oh, this is what it looks like. This is what it feels like to straighten my knee, to bend my knee, to da-da-da-da. And they have better outcomes post-surgery.
Wow.
Yeah. It's like a standard thing. So if you wait to connect to your core until you have a cut from your skin to your uterus, you can see how that would be not ideal.
Yeah.
Like, you're cutting through nerves. Nerves are what help you be connected to your body. So do the core training now, before pregnancy, during pregnancy, so that after you have that massive surgery, you don't need to rely on sensory input, but you can rely on motor memory. And you can engage your core just by thinking about it, even if you can't feel it, it's swollen, it hurts.
And the other thing that caught my attention was you mentioning at the beginning of the conversation, your throat muscles are attached. It's like, how?
Yeah. Yes.
What?
So I would use the word they're connected, but they're not attached. It's like they work together they should be harmonious with each other. So you do know this because when you have a bowel movement, sometimes you close your throat or use those muscles in coordination with your abdominal wall, and then you open your rectum for the bowel movement to pass through. That's the coordination. Or like if you were choking on a piece of food right now, I could punch into your stomach and the food would pop out. That's how your throat and your center are connected. And so for sure, during labor, I mean, not even just for pushing, like we'll teach women, if you have a relaxed jaw during labor, you have a relaxed pelvic floor.
What?
Like we also say, if your pupils can dilate, it helps your cervix to dilate. So that's why you do low lights, quiet, ideally. I know. And so
What?
The way I would put it, I have a mentor who uses this phrase and I love it. You can't make it happen, but you can make it welcome.
Ooh.
So like you raised 3 babies. Can you make them sleep?
No.
Yeah, you can't. But you can make it welcome. Mm-hmm. Like you can feed a baby and then change them and swaddle them and do the shushing noise and sing them a song and sway and have the room dark and put them down sleepy but awake. Like there's strategies that can really improve your chances for that baby to take a nap. Sometimes you do all of them and that little bee won't nap. And you're like, what is happening in my life? But it doesn't mean that you shouldn't do those things.
Just come into a pillow.
You should still do those things because oftentimes it works. I remember being taught that as a mom. Like my newborn would just fall asleep in my arms, so I would put him down. And then before you know it, a month later, he won't fall asleep unless he's in my arms. So I had to learn those strategies, and they helped. And I didn't ditch the strategies because one time he didn't nap or that whole week was off. It's like, this is what we know that can work and can support you. So do the things and know that most likely he'll take a nap.
Okay, but let's say people didn't know that, they didn't do the training. Now they're leaking, and it's like, I'm embarrassed. I don't want to tell my husband.
Yeah.
I don't want to wear diapers.
Right. No, you don't. You don't.
What happens then? How can you help? How can someone in physical therapy help at that time?
Yes. Yeah. That's a great question. Yep. So helping a woman with incontinence always starts with what we said about our visits, is that we hear them. We meet them where they're at. So it always starts with a thorough history, because we need to know if she's leaking with a cough, sneeze, laugh, lift. Are you leaking on the way to the bathroom? Do you leak and you have no idea that it's happening? Like, these are different categories of why you would lose urine. So we need to have a thorough history. We need to know if she had pelvic floor trauma, how many deliveries, how long was the pushing. All these details really paint a picture of what her body is going through. After that thorough history, we do a thorough exam. I mean, we check how your spine moves, how your leg moves each direction. We do check the pelvic floor. Is it resting open? Is it tight? Is it weak? Does it have poor coordination? Like, yeah, maybe you can Kegel, but your abs are like bulging, or you're holding your breath, or your whole body is participating in a pelvic floor muscle contraction, which should not be. Like, you should be able to just contract your pelvic floor, just like you're able to bend your elbow. You shouldn't have to do this to bend your elbow. If you do, it's a problem with your shoulder, right? Like, there's normal patterns of motion, and then there's substitutions where we're like, let's tease this back. See if we can, is it a connection problem? Does she not feel that space? Can she not talk to it? Is it painful? Does it hurt when she relaxes? So she's always a little tight. Like, you have to really dig deep and understand all the layers that are going on with her body.
Is it safe for women to have sex if they have that leakage problem? Should they stop? Like, what? Help.
Yeah. Yeah, that's a great question. Yeah. So yes, there's typically no reason why you have to stop having intercourse if you're leaking. You definitely want to make sure that you're keeping the integrity of the skin around that area intact. So you do need to wear pads while you're healing. It is not a permanent solution, but yeah, you have to keep your underwears dry, so you're going to put some kind of pad there. It needs to be absorptive and not let your skin break down, because that's a problem. And if you have skin breakdown or any compromise to the tissues there, like wounds, then yes, you should not have intercourse. But incontinence alone should not preclude you from intimacy on any level.
How, like, do people need to have a referral to be able to see you? How does that work?
Yeah, that's a good question. So in the state of Florida, you don't. You can come see us, and for 30 days, we have that time to assess you, treat you. We send our paperwork to the doctor, we fax them, and then they sign off on our plans of care.
How long can this process of healing, what can people expect in the length of that program?
Yeah, that's a good question. So for an incontinence to improve, we usually see a change in symptoms by that third, fourth visit, and that's important for us. We need to know that it's working. After that, we tend to follow them at some pace for at least the first year postpartum. And so if they're 5 years postpartum and they're just seeking therapy for incontinence, typically that 3 months is where they know it's working. They have a good understanding of their personal exercise program, and we've been able to educate them on progressing it. Now, our treatment approach is different from most physical therapy in that once we hit that 3-month mark, we really do want to keep seeing them at some pace. And it's for all the reasons we talked about. There's motor memory, there's patterns of postures, of holding that we haven't yet discovered. And so my preference is to follow them once a month for however much longer. Because remember, they also get spinal mobility and some specific massage and fascial release. Your body just feels amazing after physical therapy. You train your core more than you would on your own. You stretch your legs further than you would on your own. Like, you just feel good. Mm-hmm. So the other thing that I love about following these women proactively, again, whether it's once a week or once a month, is we see less frequent panic calls. Oh my gosh, I saw Dr. Belinda 6 months ago. I was doing great, and all of a sudden, I'm leaking again when I run.
Aww.
And not only is this a rough experience for her physically, but the extent to which we see these women spiral downwards is heartbreaking. Like, really, if you're thinking, oh man, I knew it was a problem. I took the time and energy and money to get it fixed, and here it's coming back. Gosh, I must really be one of those broken women, like for real broken. When really it's just an innocent pattern of previous postures or motor control, poor coordinations creeping back in.
And there's a way to help your body heal even if that happens.
Yeah, absolutely. Absolutely. Typically it's easy and it's a shorter treatment afterwards. And that's why if we just see you at some pace, say once a month, we have the eyes to identify those changes coming from a mile away.
Got it.
And we can prevent them to where you don't even feel them creeping in.
And I know this doesn't happen to anyone or anything like that, but what about hemorrhoids? Does that has anything to do, like, obviously all of this happens.
Mm-hmm.
I know it's very uncomfortable, kind of like,
Yeah.
hey.
Yeah.
But can physical therapy help with hemorrhoids and those? Okay, tell me more later.
Yeah, absolutely. So to keep it on simple terms, hemorrhoids can be where blood vessels get swollen and sometimes they come out of the rectum. Okay, so you can see them as just like tissue sticking out. The physical therapy can help in a couple ways. So we can help harmonize the pelvic floor muscles so they're not being pulled or tweaked to where they're, instead of having proper position, they're being pushed out. The other thing is, like I talked about, pressure management. So we can help make sure that you're exhaling as you have a bowel movement, or if you're doing exercise, that you're using the pattern of your breath to maximize the position of your pelvic floor. We can do release work. Sometimes a tight pelvic floor or even just a tight rectum can cause those veins to come out, the blood vessels to come down. And once you have hemorrhoids, you really want your bones and your soft tissue released to maximize the potential of those structures going back up and in.
And what does treatment look like? Is it like you guys physical? Is it breathing? Is it both? Like, how does it look like?
Yeah.
What can I expect? It's
Yes.
such a like, I wouldn't say invasive, but like.
Yeah, it feels like a lot.
Yeah.
It feels like a lot. I remember, we talk to our patients about what we're going to do, and we always get consent before we do anything. I'm thinking this, that, and the other. Are you okay with that? And I remember one of my very first patients. I was nervous. I was a newer pelvic floor therapist, so I gave her every detail. And she looks at me with like this flattened face, and she was like, "That's a lot." I was like, "Well, it is, but I'm the one doing it. You can just hang with me, and if they decline it, we can do a lot of other things and get to the pelvic floor the next time." I'm a big fan of keeping things simple. And if any component of what we do feels overwhelming, we can either piecemeal it or we can do that whole part later.
Got it.
Because truly, correcting your neck, your rib cage, your spine, your abdomen will improve hemorrhoids, incontinence, pelvic floor pain. They really are connected to the point where you can feel better before we even touch your pelvic floor.
When I have research on those topics, there's only surgery as the solution. And it feels like, why would you do surgery for
Right.
that in that place? Like, what the fluff?
I know.
Like, what's
Yeah.
going on? So this is not common knowledge. It's not even Google doesn't even know this. Hello.
We're trying to change Google. We're putting those search words every week. I know, yeah. So specifically for hemorrhoids, surgery is really painful. I've only personally seen a handful of patients post-surgery for hemorrhoids. I have heard pretty scary reports of how it feels to go through that. Just like anything else, sometimes surgery is necessary, and we do not poo-poo surgery as a blanketed approach. I mean, sometimes you have to have surgery, and thank God that
There's
is an option. Like, thank you for the surgeons and for the amazing technology we have. They're minimally invasive now. It's really pretty largely agreed upon that surgery should almost never be a first line of defense with the things that we are talking about. So even if you're referring to incontinence and having surgery to handle your incontinence, one common option is a bladder sling.
What is that?
They're essentially putting a sling around the bladder. They're putting a structure to keep that organ up in the pelvic bowl. And so oftentimes, we can mobilize the bladder intravaginally. It's right there. It's a saggy bag. We can, with our finger, slide it and see what position it's in relative to the hip sockets and allow it to come back to midline. Sometimes that harmonizes the pelvic floor muscles by itself. If an organ is not happy, the musculature around it will guard it. It's a natural, you don't even need to think about it. You just will. So we can mobilize the bladder with our fingers, so that's much nicer than surgery. 2, if their theory is that the position of the bladder needs to improve so that their pants can stay dry, we can change the position of our bladder by tilting our pelvis. If we are in a butt-tucked position, which only every pregnant and postpartum woman is, then your pubic bone goes from being a shelf to being a slide.
Oh.
And so if you're commonly just in this curled position, then you're training your bladder
to go down.
And then if you have poor pressure management, like you cough and all the pressure goes down,
yeah,
this poor little sack of tissue has no hope.
Yeah.
But if you learn to more often than not have a proper alignment at your pelvis with sitting, standing, walking, then you're encouraging the bladder to stay up. And it has natural support systems in here. And it should be able to be in a better alignment so that when you cough, there's not all this pressure coming down on it.
Dear Lord, have you ever gotten any pushback from husbands or that they may not know? Because I feel like there's a big misconception of physical therapy, that's for sports. Mm-hmm. Physical therapy, that's when you have surgery. But I don't think a lot of people associate it with pregnancy or all these things. What would you say to someone who may be experiencing that?
Like if their partner is questioning if this is really what they need. Yeah. It's been really cool to see the evolution of this with partners, with even parents or physicians. Initially, I did hear a lot of pushback. So when I started the company, I was the one doing the initial call to screen them, make sure they're appropriate for therapy, and then explain to them what I could do and what it cost and what it looked like. There were times where I had the husbands on the phone. And they would, I don't know, let me talk to the doctor, said no, or, oh, you don't take insurance, so I don't think so, we're going to go elsewhere. I don't know if it's increased awareness in the community. I don't know if it's because we've developed this reputation over years where we have earned the trust of other care providers, but we are more and more often hearing husbands be like, I've been telling her to get this taken care of, and she needs this. I'm not even telling her, this is her Mother's Day gift. I'm going to get her this because my friend told me that you helped his wife and she just felt better. I will say that they are very on board if we explain that we can help with pain with intercourse. They typically say yes. And that's fine. I'm great. Love it. Yes. High five. Have a healthy sex life. You should. And I'm seeing a trend where they're wanting to support their wives or their partners, even if that's not the only thing.
That's beautiful.
Even if it is moving around. We had one guy recently call in. This is an example. He called without talking, or not without talking to her, not like he didn't have her consent, but it was like he called and he spoke to the therapist that works with me who does the screenings, and she told the rest of the crew, she's like, I just had the best phone conversation with this husband. He said, listen, Dr. Cassie, I did this to my wife and she's miserable. He's like, I didn't mean to. We have 2 kids. And she was like, okay, say no more. I got it. He was like, yeah, but now she's pregnant again and she's miserable and she hurts. And I heard you guys can help her. So yeah, it is
Bless
like
his
really
soul.
turning a corner. I know, right? So cute.
And I mean, it does help that if a woman's going through that and it's making it painful for her to have intercourse, that like everybody can be happy. They can be happy.
Yes, he's
the wife can
directly
be
involved
happy.
with that outcome. Yeah, absolutely. Yeah.
What should men know about this process? I feel like more men now are more aware or more, I don't know, gracious. Then there's some that they don't even know.
Sure, yeah.
What should they know about this whole process, or how should women communicate to them? Sometimes we don't even have language, or we don't know how to communicate like these specific things.
Mm-hmm.
You're the doctor. You've seen this before. What would you say?
Yeah. I mean, from a physical therapy perspective, I would say this treatment type is science-backed, research-supported. It's been evolving over the years, and we use the most up-to-date strategies so that we're effective in what we're trying to achieve. So to say you should get the outcome. I mean, we listen to your problem in depth. We really understand what's going on with the body. And if we say, yes, we can help you, we can help you.
I love it. So before even signing up, is this program for everyone, or how does the screening work?
Yes. So we do screen patients before we start working with them, because we do need to know from a clinical side. Sometimes she'll tell us something that's going on, like say she mentions that she's on pelvic rest, which is not bed rest, but it might mean certain things like she cannot have intercourse. Sometimes physicians will use that term if they don't want her exercising in her pelvic floor or maybe her hip musculature at all. So we want to get that information so that we can connect with the physician before the eval, but we're still evaluating her.
Got it.
We just need to know. Sometimes they're calling in and they're talking about a problem, and they actually have something else going on, and we want that cleared before we see her.
Got it.
So I had a woman call who was telling me about her pain patterns, and I was like, this does not sound right. She had stabbing pain in her mid-low back, kind of sometimes my side, and it comes out of nowhere. Out of nowhere? Like, are you getting up from a chair? Are you rolling in bed? No, it's just like this stabbing pain out of nowhere, and it knocks me to my knees. Does it have anything to do with when you eat? And she's like, now that you mention that, it's like an hour after I have a meal. I'm like, okay, I feel like I might want you to go to the ER because one of your organs might be really mad. Like, there are times where we get gallstones, we can have appendix issues. There's an overall slowed metabolism during pregnancy. So we process our food much slower. That's why we can have constipation more often, bloat. So yeah, organs, we're more predisposed to stones, kidney stones even. So, and then the other thing is I've had women call in who are in labor, and they're like, I'm 39 weeks and my back is killing me. Can you still help? Absolutely, we can help. Let's ask a few more questions. And then she's like, it's like every 5 minutes, something's just grabbing my back. And I'm like, how long has this been going on? Like 4 hours. Okay, let's call your midwife. And if you get a gush of fluid, that's your water breaking. Like it can present in different ways. So sometimes women don't know they're in labor, which I don't blame them. You've never been in labor before, you might not know.
Yeah.
And you might just think you're having back pain. Yes, so we screen them ahead of time. We make sure they understand most of what we're gonna do. So they're consenting, they're excited, they're like really understanding the concepts behind it before we come to their home.
I love that.
Yeah.
So I'm glad to know that there's actual support
Yes.
or help to prevent it or to recover it, like
Yes.
to come back to wholeness.
Yeah, back to homeostasis, dry pants and pain-free sex, yeah.
Yay. So do you have any resources that may help women that are going through this? Anything at all?
Yeah, absolutely. So we have a handout to distinguish the different types of incontinence.
Okay.
So there's a few different types. And if you even are empowered with the understanding of which is which, that by itself can start to give you a roadmap to what you can do to heal it.
Beautiful. So we're going to put a QR code in the frame so people can go and take those resources and just download them, check them out.
Yeah.
And then for anybody else who's looking for even more support, like what's the next level? How can they find you?
Yeah, absolutely. So like we said, we were talking about, we do those free 15-minute consultations with a doctor of physical therapy who specializes in pregnant and postpartum women. And so that we schedule 5 days a week from 9 to 4, and we can not only understand what your issues are, but give you a little tip of where to start. And then we're also able to schedule you for either an in-home session or telehealth, should that be appropriate.
Beautiful. And when you say right after postpartum, can women that, like me, have had a baby like 3 years ago, can I still, is that something that I can do, or is it too late for me?
Yeah, absolutely. So we've worked with women who are 2 weeks postpartum. We've worked with women whose babies are getting married.
Wow.
Yeah.
Awesome. All right. So where can they find you?
Yeah. So you can follow us on any social platform at Painless Pregnancy, and the website is painlesspregnancy.com.
Beautiful. So now you know where to get them. Thank you for watching, and see you in the next one.
Take the next step towards a pain-free pregnancy. Schedule your free 15-minute consult at painlesspregnancy.com. Like, share, and subscribe for more empowering episodes.